of the Heterotaxy Program there. So we'll move on to the next talk. For my portion of this talk, I have a few goals. I'd like to explain the rationale for a heterotaxi program, share some tips to start building a local heterotaxi program, and then introduce the Boston Children's Hospital Heterotaxi Program. And just by way of background, we at Boston Children's care for a large number of patients with heterotaxy. This shows our data for the last few years. You can see that we care for between 250 and 300 patients or so a year. And what I appreciated was that because many of these patients were coming through cardiology, there was obviously a very cardiology heavy focus to these patients. Lots of detail about the anatomy, about the physiology, and the potential surgical approach. But what happened was some of the non-cardiac issues that can come up with heterotaxy were essentially left as secondary questions or sometimes unknowns before a patient was going for a major procedure. And as everyone knows who is attending this meeting, heterotaxy certainly can affect multiple organ systems. Here's an example of 3 patients that I've cared for. The one on the left with polysplenia, hypoplastic left heart variant, and biliary atresia. In the middle, a patient with polysplenia, complex transposition, complete heart block, malrotation, and duodenal atresia. And on the right, a patient with asplenia, dextrocardia, and a complete atrioventricular canal defect, biliary dyskinesia, and malrotation. And so I started to wonder how all of these abnormalities were interacting to affect the well-being of any given child. I wondered what was the best management strategy, what was the best order to treat things, and I wondered if a multidisciplinary approach would be helpful in caring for a child. And so really the mental model for caring for a patient with heterotaxy shifted from something that looked like this to something that was a little bit more balanced and addressed all of the potential organ systems that could be involved in a patient with heterotaxy. So over the next few slides, what I'd like to share is just some thoughts about how we went about building a heterotaxy program. And so I'll take you through our initial steps, how we then went about operationalizing our program, and then share some ideas for ongoing success. So first and foremost is to identify the patients with heterotaxy. And I'm actually going to let Dr. Spurgin speak in more detail about this in just a few moments. But suffice to say, this is a critical question. It's not always easy. And sometimes just deciding how a patient is going to be defined as heterotaxy can be a complex question. Certainly, a critical component is to identify providers who are willing to be institutional champions. These can be individuals in your department or across departments. It can be as simple as looking on your hospital website or perhaps speaking with division chiefs in other departments. As far as an initial team goes, we felt that having a robust cardiology presence, immunology presence, pulmonary presence, GI presence, and genetic presence were really the key components. And the reason I say presence and not a specific provider is that this can look a little bit different from institution to institution. Certainly, as far as cardiology goes, electrophysiology can be very helpful, seeing as many, if not all of these individuals will have heart rhythm disturbances. Having partners in intensive care and in advanced cardiac therapies or heart failure transplant is very helpful. And then among surgical colleagues, those with expertise in complex anatomy and situs abnormalities can be very helpful. I list next immunology, hematology, or infectious disease, and that is because I think any one of these providers can help to address the immune dysregulation that can occur in heterotaxy. And it's really not so much about having someone from a specific department, rather it's more about having an individual who's interested and motivated to help care for these patients. With regard to pulmonary medicine, hopefully that's evident at this point in the conference. having a provider who can help care for individuals with ciliary dyskinesia, but also having a partner in ENT can be helpful. With gastroenterology, certainly having a partner in hepatology can be helpful, given the possibility of biliary atresia, and then having a partner in general surgery can also be helpful. In terms of operationalization, defining the initial target population is important, and then what I would suggest is growing in a stepwise fashion. So we began with neonates in the intensive care unit because they were a captive population, if you will, and relatively easy to do consultations and communicate with providers in an ongoing fashion. We then moved on to all inpatients, then regional surgical patients, and then any patients who were seeking an outpatient general heterotaxy consultation. And then one of the things that I'm most proud about our program is that we've moved on now to doing prenatal consultations for families affected with a prenatal diagnosis of heterotaxy. It's important to clarify the process, especially with regard to documentation and billing. So things that one wants to consider are these going to be individual consultations with each subspecialty doing their own consultation, or will there be one individual bringing everything together and creating a summary note, or maybe a combination of the two? Will these be inpatient consultations only, inpatient or outpatient, or some combination? And what is the cadence of visits and documentation that is going to be a part of this? And also exploring with billing and financial will be helpful to make sure that you're getting adequately reimbursed for the services that are being provided. Meeting regularly, refining the process, and learning from one another is also critically important. So having some sort of forum where we can get together and review patients has been extraordinarily helpful. I know I learn something new every time I gather with other providers in our heterotaxy program. And then in terms of ongoing success, support is important. You'll want to look for funding opportunities potentially. We have a program coordinator that is extraordinarily helpful in gathering together all of the information and prior documentation on our patients. We're extraordinarily fortunate to have a nurse practitioner supporting our team, who you're going to hear from in just a moment. That's Caitlin O'Connell. It's important to engage trainees. Heterotaxy can be intimidating, but it can be very engaging. And what I found is that many fellows and residents very much enjoy caring for patients with heterotaxy. And then finally, collaborate, especially as the HRC3 continues to grow and is supported and collaborates with the Heterotaxy Connection. There's going to be more and more opportunities for collaboration. There is a forthcoming heterotaxy care toolkit, a forthcoming registry, and we hope that this will evolve into a yearly conference. So this is our current Boston Children's heterotaxy evaluation. I don't have time to go into each individual detail, and much of this you've already heard. But this is our approach, which we've evolved toward after a few years of being a program and lots of refinement. And I will say that this largely aligns very closely with the review paper many of the authors you've heard speaking here today. So this is a great resource to look toward, in addition to resources forthcoming from the HRC3. And this is our program. I won't read every name, but suffice to say, I am very honored to participate in the care of children with heterotaxy with this wonderful group of individuals. And we remain very available to answer questions should they come up. And with that, I will turn it over to the Boston Children's Heterotaxy Program nurse practitioner, Caitlin O'Connell.